So thanks for having us. We're excited to hopefully, give you a couple new tidbits of things. Some of it will probably be things that you've heard before, but we always hope that you can take something new out of what we talk about. So first, to kind of start the discussion off, we're going to talk about a concept called neuroplasticity, which is a big word that basically means that our brains are able to change. They're able to be molded and, create new pathways based on the input that they get. And we kind of take this concept for granted, but without that ability to mold and change, really, we wouldn't have a career because we are in the business of driving change in people's brains. So in order to have that happen, in order to see that change on the brain level, there's some really key pieces of neuroplasticity. So one of them is intensity, or how hard and how much of an activity that you do. So it's the total time that you're practicing and the amount of effort and energy that you're putting in. So much of the research behind what is effective for helping folks with Parkinson's is that it has to have this intensity piece. It has to have some challenge behind it. Another piece of it is specificity. So that means we're doing specific things to change specific outcomes. So basically the concept is what we're having the greatest issue with is what we really have to hone in our practice towards. And as we kind of unpack the rest of the discussion, more of this will kind of come together hopefully to make sense in more specific ways. Concepts that we talk about is what's called use it or lose it, which is more or less the more that you do something, the more that you practice a certain movement, you're going to keep it. If we stop doing that, we often lose that ability to do it. I think a perfect example of that was kind of during the COVID pandemic when so many people just stopped doing their regular day-to-day activity. And we all found that, oh my gosh, the second we tried to go back to doing our old routine, a lot of us had lost just that kind of baseline foundation behind things. Another concept is called use it and improve it. So not even just that ability to maintain whatever function we're working towards, but to actually get better at it. And then based on the deficits and based on, again, the stage of disease that we're talking about specific to Parkinson's, sometimes we have to approach this a little bit differently. Our third bullet talks about repetition, repetition, repetition. So if we need to practice and get better at something, we have to do it a lot of times. I think, we think or we hope that once we practice something a few times, we'll automatically get better. But really, we have to have a ton of practice of these tasks that we're really trying to see change with. The next concept we're going to think about is the difficulty or the challenge of the task and how much kind of cognitive engagement that requires. Especially with Parkinson's, one of the concepts that is, a blanket across the disease is that things become less and less automatic. So where before you could kind of do things without ever thinking about them, as Parkinson's progresses, that automatic nature of things becomes a lot more challenging. So we want to continue to engage that brain and keep the brain in tune with what we're doing to hopefully keep, making things that are currently challenging a little bit more automatic. Ways that we can do that is by changing the environment, changing the cognitive load, so adding some kind of thought to it. And just effort alone, so just working really, really hard, let's say on the bike or the treadmill, may not be enough to really see change in activities that require a lot of coordination. And then the last concept on this slide that we're going to talk about is what's called saliency, or that meaningful to you activity. So if we're doing an activity and you're only doing it because so-and-so said you need to do it, and no part of you at your heart knows that it's important or feels that it's important, that brain is actually less engaged to change. So we need to be doing things and doing exercise and activities that are motivational and that are important to you and that you're seeing that personal benefit. I can think it's beneficial for you all day long, but until your brain perceives that sense of reward, we're not going to see that same level of change. Okay, so as a little kind of summary of that neuroplasticity concept, when we're talking about exercise in Parkinson's, in order to change the structure of that brain, it has to have intensity, specificity, salience, complexity, and repetition. So at the core, those are really some of those things that we have to have. We need to kind of think about having a mixture of both very skilled and targeted training towards specific deficits, but then also aerobic training or exercise, in just a heart rate aerobic heavy way. And that's, coupling those two things is really where, again, we're going to see the best change. In early stages of Parkinson's, we really want to be pushing folks, or that's our job, is we're really pushing folks that we should be as good or better than your peers that don't have Parkinson's. We really want to be starting off early in that diagnosis with a foundation, because again, we know that this is a progressive disease, but the kind of understanding of how we can manage this disease has changed so much, even in just, I've been a physical therapist now about 10 years, and just the thought process behind movement and exercise, even in that span of time, I've seen it change dramatically in my career. Nowadays, I would agree, I'm getting folks that when they get a Parkinson's diagnosis, they get a PT referral, which is such a beautiful shift in kind of how we're thinking of it. Whereas before, I was finding I would see folks after their first fall or after things are getting, really tough from an independent standpoint. And when we intervene early, we really have the greatest success. In later stages of the disease, we often do need to kind of change our approach a little bit and add a little bit more of what's called external cueing, which we'll go into a little bit later, and a little bit less complexity, because again, that ability to kind of do two things at once does get a little bit more challenging in those later stages of the disease. So some common questions that folks often have is, when do I start going to physical therapy? When is it too early? I sometimes have those folks that early on in the disease, they get referred and they come to me like, I don't really know why I'm here. I'm not having a ton of issues. And I always say, perfect. That's the best time to come because we can really intervene then. If you weren't referred early on and it is further in the disease, that doesn't mean there's not change that can be made. We, at any point, and that's what we're going to be really talking through today, at any point can really step in and hopefully make some real change in the quality of your life. And then how therapy changes over time is, again, really the focus of our whole presentation. But at the end of the day, it's our role as physical therapists to meet the patient where they're at with what their goals are, what it is in that stage of life that they really want to be able to do. Are you wanting to keep up with your spouse on a hike? Are you wanting to be able to safely pick up your grandkids from the ground and walk around? Are you wanting to still be able to go to some exercise classes at your gym? All those little things that are motivational and important to you as an individual. That's the critical piece of physical therapy, is it's individualized to your specific goals. So this is kind of that idea of kind of the model that we've seen change with the idea of exercise and physical therapy over time. Kind of our old model was that we would see the diagnosis, people kind of just kept living their life the same without much change. And then we did see folks progressing into these further stages of the disease. Really, our goal now is that early on, we're working to slow the disease progression through exercise and really task-specific exercise so that we never are hitting those real end, stages of Parkinson's disease. We would love it if folks are, like we say, kind of dying with the disease, not of the disease. We want to be that we have Parkinson's, but it's other factors in life that are affecting us. So we're really aiming to drive forward that change and create this new model of care that thankfully now I feel like is really becoming standard of practice, which is fantastic. Okay, so we're going to move into now a little bit more of some exercise specifics. We've broken up the presentation into different stages, kind of thinking at diagnosis or early stage, then we're going to talk some mid-stage, and then kind of some later stage considerations. Some of the things that we talk about in each stage are applicable at multiple stages, so don't think just because we only talked about it in one part that we don't do it in other parts, but just to avoid too much repetition, we've kind of organized it in a way so that we can kind of focus in on certain key aspects at each of these stages. So here we're talking about stage 0 through 2 on the Hoehn-Yahr, which, if you're familiar, is kind of how the neurologist categorizes how severe the disease is at that time. So these are these early stages of the disease. Some of the things that we see in this kind of early stage of Parkinson's disease, usually at diagnosis, is what we call bradykinesia, which is a slowness of movement. Oftentimes, walking speed is getting a little bit slower. We may have that early resting tremor, small handwriting, or kind of a quiet voice. We may start to see some of that change in posture, that kind of forward flexed. Sometimes that kind of masked facial expression. And then some kind of muscle stiffness, or what we call rigidity. These are often the signs and symptoms that get people into the neurologist. It's the kind of classic early things that we think of in kind of diagnostic Parkinson's disease. So these are what we're kind of talking about. All of the information that we're going to be talking about with these recommendations for physical therapy come from what's called a clinical practice guideline, which is more or less a summary of all the evidence that exists in physical therapy that has been shown through research studies to be beneficial, so that we're not just kind of saying this because it sounds good. All of this comes from a really dense body of literature that's studied this specific to folks with Parkinson's. So by now, if you've either heard a physical therapist talk or your neurologist talk about exercise, hopefully you've heard about the critical importance of aerobic exercise. Aerobic exercise is that, cardiovascular, things like biking, swimming, hiking up with hills, anything that gets that heart consistently pumping over extended times. The real key piece with the aerobic exercise, though, is that in order to really drive that change at the brain, it has to be moderate to high intensity. So unfortunately, just kind of, sitting on the recumbent bike with a nice book and maybe a cup of coffee kind of swirling our legs around doesn't really drive that change that we're hoping to see at the brain. I like to use the terminology of think of it as hot and sweaty exercise. So it's the exercise that you're working hard. If you were talking to somebody on the phone, they would very clearly know that you're exercising. It's not enough, like I said, to just kind of go through the motions, so to speak, or kind of just do it at these lower intensities. Some of the benefits of aerobic exercise, one is that it improves our what's called VO2 max, which is that volume of oxygen that our body can uptake. Aerobic exercise is also the thing that really decreases the severity of this disease. So that blood flow that's getting saturated up in the brain, this is really, in my opinion, one of the most key pieces to slowing the disease progression. It also improves patients' functional outcomes, which is more or less how well they can do day-to-day functional tasks. And it also improves quality of life. And those, again, are coming from research studies that have looked at this, not just our opinions that it improves quality of life. Most of the studies that have been done typically use like treadmills or stationary bikes, really because, again, if you think from a research standpoint, those are the easiest to collect data. But like I said, it can be swimming, it can be walking at higher speeds or with hills to really drive that heart rate change. Things like rowing. You can be creative. If you hate the stationary bike, we don't want to force that on you. It has to be meaningful, and it has to be something that you enjoy, or at least can do with some sort of looking forward to. The next piece is resistance training. So that's real, what we think of like weight training or building muscle capacity. Some of the benefits here, again, we're reducing that severity of the disease course. We're improving power, which power is it's strength and speed. So think about that ability to get up out of a chair, to do that with power. To get off the floor, we need speed. It also obviously improves our strength when we're building strength. It reduces some of our non-motor symptoms as well. Again, we're talking about improving function and quality of life. Now, again, you're going to feel a common theme here. In order to really drive change, the strength has to be challenging enough that we're really loading our muscles. We either have to be working it at 80% of a 1 rep max, which is more or less how much your body can do for 1 repetition. We want to be working at a high enough intensity or with that speed component behind it. Ideally, we need to be getting at least 2 days in a week, 30 to 60 minutes, and then performed kind of over the long term. I also made a note that ideally we want to focus on what are called our extensor muscles, which more or less you can think of as the muscles on the back side of our body. So in Parkinson's disease, classically the posture that we see folks kind of start to take is that forward flexion. And so in order to combat that, a lot of our strength focus needs to be on those extension muscles that help keep us upright. That disease course is automatically going to close us off, and so much of what we try to do is strengthen in the reverse to keep us upright. And then balance training. We know that a really common thing that we see, especially in mid and later stages of the disease, is changes in our balance, leading to falls. So when we can start balance training early in the disease, again, we see improved outcomes later on. Some of the benefits is just improving that postural control, or that ability to kind of move your body through space and know how you're kind of going to react or recover. We see improved balance and walking outcomes, and we also see improved mobility and balance confidence. And when we have better confidence, we're more likely to get out and about and be more active day to day. We're also seeing improved quality of life and some of these non-motor symptoms. Typically for balance training, supervised balance training, so under the care of maybe physical therapy, is typically better than less supervised. Really what I often tell my folks when I work with them is that the aerobic exercise and even usually the strength exercises, I like to train people on and then say, okay, this one's your job outside of PT. But in order to really work on balance, we have to be training it to that point of it being challenging. And you can imagine that it's a safety concern if I'm going to go tell somebody at home to challenge their balance. If they're a fall risk, I don't want to be causing a fall while you're trying to practice not falling. So typically I prefer to have the training, especially early on balance, be supervised under our care typically, or any physical therapist's care. That way we can do supports like harnesses, overhead support, or even just things like bars, or we can physically guard people. Typically we need 2 or 3 times a week over a extended period of time. And then again, some of our focuses are on, single leg balancing. So being able to just, stand on one leg, not that that's a, perfect representation of balance, but it is an important one. Things like functional reaching, or that ability to move outside of your kind of narrow base of support. And then moving in different directions. Our life is very forward driven. We walk forward. And some of the things that happen early on in Parkinson's is that lack of confidence and stability in moving sideways and backwards. So early on, I like to introduce that ability to, hey, can we recover well? Can we move side to side and backwards? So that it becomes more and more natural as balance does tend to change. Flexibility is one of those things that to me is not a standalone part of exercise in Parkinson's, but one that I do think is an important thing to keep in folks' plan, because we know that that rigidity or that muscle stiffness is a really common complaint in folks with Parkinson's. And though we can't outstretch some of that rigidity, it is really important that we do maintain the passive range of motion throughout our spine, throughout our hips, our ankles, our shoulders, so that over time we're still able to do the things we want to do. Like I said, this really is not a standalone type of treatment. Never am I saying stretching alone is enough to really, help things out, but I often encourage folks to have some sort of flexibility programming in to keep them moving well. And then we're going to talk community-based exercise. So this is your things like rock steady boxing or any other kind of group fitness, Parkinson-specific community exercises. I'm a huge advocate for them because you typically are not going to see a physical therapist forever and ever. We like to set you free, and oftentimes out into the community at some of these programs is the best way or a great way to keep good accountability on exercise. Some of the benefits that we see with these community-based classes are decreasing that motor disease severity, improving some of our non-motor symptoms, improving function and quality of life again. Again, it is so critical that it's effective and that it's important to you, because if you don't like going to a certain class and you're going in and you're just dragging yourself through the door every time, we're again not going to see that same quality of change in the brain. So many of my folks that participate, specifically in Rock Steady, it becomes a community for them. People are just so excited to walk in that door. They're excited to see their friends. They're excited to, challenge themselves and try something new. And that's perfect. We need that importance. We need that meaningful, meaningful change to you. Again, you don't exercise, though may not at the start sound exciting or fun. It does. We do want to try to find something that to you is somewhat enjoyable so that you'll keep up on it. And then task-specific training. So that's things that we're thinking about that just exercise alone may not target. One of the things I'm going to kind of highlight is practicing turning training. So one of the things folks get screened for oftentimes with Parkinson's is how well they're turning. So your neurologist may say, okay, I just want you to turn 180 degrees, stop in place. And we see very commonly that in Parkinson's we start to get these kind of short, shuffly turns. It takes a lot of steps to make a turn. And that's one thing that when we can practice that specific task over and over and over again, we really can see change. That's a task that a lot of my folks tell me has gotten hard or has gotten frustrating. And so lots of practice of something very specific, such as turning, is really, really important. And then dual task training, which is more or less doing two things at once, or having your brain think about one thing while you're doing something else, is something that oftentimes we'll implement. And then fall risk training, so kind of like fall strategies or things like that, is not something we necessarily want to work on in those later stages. We want to do fall prevention, but actually practicing falling may not be the safest thing to do in later stages. Okay, so this I've been hinting at a little bit, but this idea of behavior changing approach is we have to, as physical therapists, be meeting clients, patients where they're at with what's important to them and what they want to actually change. Motivation is such a key piece of driving change in any of us during any, behavior. If we don't really think it's important to us, we're not going to do changes to make that happen. So having appropriate goals that we're working towards, actions, taking steps towards these things is super, super critical. Okay, so one thing that we often talk about as well in this early stage of the disease, this isn't as much exercise focused as it is more of just a lifestyle management thing that physical therapists will often work with their patients, is managing what's called orthostatic hypotension, which is that sense of getting lightheaded or dizzy when we change positions, either laying to sitting or sitting to standing. It's a really common phenomenon that happens in folks with Parkinson's disease, and not only can cause, dizziness, lightheadedness, but if severe enough, can actually make you pass out, which obviously has its, scary risks if we fall down and hit our head because we're passing out. So oftentimes when you're seeing a physical therapist, we're screening for this, we're talking about it, because there's really some great lifestyle management things that we can do if this is an issue, especially early on. Some of the management strategies, one is increasing our hydration intake. So it's so critical that we're getting enough water. The target is 2 to 3 liters a day, which that's a lot of water. But increasing it all is better than not at all. Increasing salt intake. So if we just drink a ton of water, it's actually going to just flush through our body. But if we have salt or an electrolyte to kind of hold on to that, it'll stay in our body longer and keep our blood pressure a little bit higher. Because basically the problem is our body's not getting the blood up to our brain quickly enough, and so we have to drive that blood pressure a little higher. This is one that we often have folks talk to their physician about, just to make sure there's not other concerns if you're upping your salt. It's the one thing, I feel like everyone nowadays says, take out no salt, no salty snacks. And for folks with Parkinson's with low blood pressure, I'm like, well, hey, this is good. We get to have your chips again. You can have some tortilla chips if you want, if it'll help your sodium a little bit. Drinking like a bolus of water, so like having a single bout of a lot of water can really help, especially if like you've been laying down all night, you're about to get up for the morning. Drinking a large little bit of water at that time can really help keep the blood pressure higher. Raising the head of the bed, so if you're laying fully flat, again, that transition from flat to upright is quite dramatic. If we can raise the head of the bed a little bit, we don't get that dramatic drop as much. In more severe cases, sometimes we do have to use like compression socks or even like abdominal compression. And then I'll often teach patients things that they can do physically. If you do sit up and you're getting that kind of like woozy sensation, I'll teach people to kind of do a couple leg kicks, cross the leg over, do a couple heel raises. When we pump the muscles in our legs, it helps kind of shoot that blood back up to our head a little bit better. So that's one that, though not directly exercise, it's a really critical thing that we're screening for, just to make sure that we're not risking passing out. Okay, so lots of information there about early stage Parkinson's disease. Again, many of those same concepts that I just talked about are still going to apply as we move into mid-stage, but we're going to kind of layer on some of the other things that we start to really think about and screen for. This we're talking about Hone and Yar's stages 2.5 and 3. So some of the common symptoms that we're seeing at this stage of the disease is a more generalized hypokinesia or lack or slowness of movement, trouble initiating movement. So when folks kind of get up to stand, it's like they feel stuck in the mud. They just feel glued to the ground. A concept called festination, which is when the feet kind of start to go slower than the body can kind of keep up with, and then we start to see that postural change. What's called freezing, which again is that if I'm walking maybe through a door or a threshold, my body will just kind of stop in the mud, and it's like folks get stuck or frozen in time, which again is a risky thing when we think about falls. You can imagine if your feet are stuck and your body's still going, folks are often really likely to fall with that. More postural instability or those balance changes that we see. And then more issues with like swallowing. And then other kind of secondary complications that we might be seeing just because we're being less active, we're not moving as much. So decreased aerobic capacity or weakness, things like that. Oftentimes at this stage of the disease, we have to start using some of those cues or those kind of strategies to kind of overcome these movement changes that we see in the body. Often early in the disease, folks can kind of just, like get past it without having to have very specific strategies. But in these mid stages, we often do need to start cueing a little bit more. So gait training or walking training is something that's often really important, especially if we're seeing folks that, our stride length is getting very small. We're having to take, 4 times as many steps to cover any sort of distance. This can include walking in the clinic or kind of just over ground on a treadmill, and should be at least, the studies ranged from 20 minutes to an hour, couple times a week. And this is really one that should be done long term. If we're seeing those real notable changes in walking, if we're seeing that festination, that freezing, that shuffling gait, this really should be implemented quite regularly and should also include that practice of turning. External cueing. So the concept here is that when your own body is struggling to, oftentimes caregivers are doing it without even realizing. They say, take a big step. And having somebody else say, take a big step, then, all of a sudden our body is able to figure that out. So what that is it's a cue outside of your body that in the Parkinson's brain and in the brain in general is a much more helpful movement strategy. We can go to the next one. So different examples of external cueing. One is auditory cues. So that's things like a metronome beat. So sometimes if somebody's shuffling like this, I'll even snap for them, I'll clap for them, we'll turn a metronome on a computer. If that's a strategy that's really helpful, sometimes I'll have them find a song that's at the beat that we want them to be walking so that you don't have to be listening to a click all the time. That could get annoying. So music, cueing, snapping, things like that. Visual cueing. So like if, for example, if I was walking on this carpet, it's got really beautiful stripes. So my brain targeting to a specific stripe to step to is much more helpful than me just saying, come on, lift my leg, lift my leg. If I can go, okay, boom, I'm stepping to that stripe, it's a much more beneficial strategy. Somatosensory or kind of like touch cueing is one. So like if a person's really, frozen in time, they're not able to step, kind of tapping the thigh, tapping the leg, even like a weight shift or a march in place. Sometimes just changing that brain's kind of movement in the moment. Rather than thinking about walking, I'm thinking about marching, and then oftentimes we can move out of that step. And then that cognitive cueing, that's things like big steps, stand tall, heel first, those kinds of things. And then one of the other things that becomes really critical at this stage of the disease is a very integrated care model. Gone are the days where there's a single doctor or a single provider that's going to have all the answers. Really, we want to be getting a team approach, that kind of multidisciplinary management. This is, I think, one of the most, important things is to know that you have a good team behind you, because all of us can approach tackling this disease from so many different facets. On this next slide, I've got kind of an example of what this kind of might look like. So at the center of it is always the patient. Our interest is that of the patient. If I have my own agenda, it's not going to be driving change for that person. So at the center is the patient. On one wing, we've kind of got our therapies, our PT, OT, speech. Maybe we have neuropsychology on board, so they're doing testing for cognition, memory, things like that. Obviously, we've got our movement disorders neurologist who's managing the diagnosis of the disease, medication management, really that true like medical management of it. We may at this point be bringing on things like social work or mental health. And then if we're having maybe considerations of deep brain stimulation, we may also be having a neurosurgeon on board. So really kind of thinking about that comprehensive team that can all approach the disease from different aspects. And then I'm going to pass it over to Kallee. Thanks for tuning in. Yeah.
Way back in your slide, you talked about resistance training.
Yeah.
How do you determine how much weight they lift?
Yeah, so that'll be totally individual to the person. We usually assess a person's baseline strength and then can provide the right recommendations. Now, if you're at the gym and you're doing it on your own, we want it to be challenging enough. Obviously, most of us don't go out and do a true 1 rep max where you're trying to do, okay, what's the most that I can do one time before my body fails? From just like a joint health standpoint, that can be a little risky, but I try to tell folks that if you're doing a set of an exercise, by the 8th, 9th, definitely 10th repetition, it should be hard enough that you need a break. If you're doing 3 sets of an exercise, and you're doing 3 sets of 10 and you could bust out all 30 in a row, it's just not hitting that challenge level. So that's the kind of best like self-assessment I give to folks. If it's so easy that you could do 1,000,000, not hard enough. If you're only able to do 2 or 3 and your body's, you can't lift it anymore, you're struggling, that's probably a little too high. We want to be hitting kind of that mid-range of, like I said, somewhere between 8, 9, 10 reps, where your body's really longing for that rest. Then we take a good rest break, 1 minute, 2 minutes, and then can often do another set after that little period of rest. Yeah.
All right. Let's try that. That might be too much feedback. All right, can everybody relatively hear me?
Yeah.
Beautiful. So we're going to be moving into the later stages of Parkinson's disease and what that looks like from a physical therapy perspective. So stage 4, we're really seeing more severe debilitations, typically using some type of assistive device. Stage 5, kind of the end stage of the disease, you're relying heavily on a wheelchair for your mobility or potentially bedridden. So those further progression of a lot of the symptoms we've already sort of discussed. That festination, freezing especially, becomes really pronounced in these stages. Retropulsion means that backwards fall where you're just standing at the sink and the next thing you know you're on your butt. Swallowing especially, and a cognitive decline. I think about 80% of individuals moving into these later stages will experience some form of dementia. Hallucinations become more prevalent, anxiety, depression, some of those other things. So from a physical therapy perspective, a lot of times what we're doing in this stage shifts. So we're still working on strength, balance, mobility in general, but we have to kind of start tackling some other things we just hadn't touched on yet. The big one's going to be caregiver training, so those loved ones in your lives. We want to make sure there's a good understanding of like how medication is evolving at this stage. So again, I'm not prescribing medication, that's not my job. But having those conversations that, there can be much more like impulsive behavior at these stages related to some of the medications. Also like worsening of hallucinations and those safety factors with those things. Transfer training. So if you do need physical assistance, like getting out of a chair, getting into the shower, getting out of bed, I want to make sure as a therapist that you and your caregiver have a great plan in place. Because if you go to help your loved one get out of the car and you pull your back or you fall and hurt yourself, then really everybody's out of luck, right? So we want to keep you, the caregiver, safe, but also like you, the patient, safe. In terms of if you are caring for someone who's bedridden, we want to make sure that every 2 hours there's some kind of position change. So if you're not shifting your weight in some kind of capacity every 2 hours, that's what increases your risk of getting like bed sores. Moving towards like fall prevention and safety. So freezing is huge. So really making sure that we're minimizing that dual tasking that Lauren talked about. Like if you are walking and you're walking to the bathroom, I want you to cut out all distractions. I don't want you talking to somebody about what's for dinner. I don't want the dog barking. Like let's try to minimize and really like hone in your focus on the task, which for you right now is getting to the bathroom or getting out of bed. And really that interdisciplinary care that Lauren was just touching on just becomes even more prevalent here, making sure with some of those swallow complications, like have you seen a speech therapist? Like are you receiving treatment for that? And not just sitting in your symptoms. Like there's always a period of time for help. So moving into like assistive devices, I think this comes up pretty often about like, well, I don't know, when should I use a cane or when should I be using a walker? One that should always be determined with you and your physical therapist, just to say none of this is blanket statements, but I always tell my patients, if you are walking from like the couch to the wall, to your husband, to the door frame, and kind of like furniture surfing, that's your brain telling you that you could probably use some type of device. So the first one being like a cane or a walking stick, those are for people where you just need a little support here and there. If you're relying pretty heavily, leaning pretty hard, then there should be some kind of consideration for a two-handed device. We're even just gonna move on to the next slide just for like a visual of the next couple. So this first one in the upper left corner, this is called a U-step walker. So if you Google Parkinson's and walkers, this is gonna pop up because this is specifically designed for individuals who have Parkinson's disease. So one of the big features is all the extra wheels on the front. That's gonna allow for a tighter turning radius and allow for more stability during the turn, which we've already touched on. Turning tends to be very hard. The other aspects of the U-step walker that are helpful, it has like an external laser that's going to provide that external cue of large steps and as well as keeping people close to the walker from a safety perspective. When I see people walking way out here with their walkers, you're just cruising for a fall. So that allows for just a little bit of feedback. It also has the ability to incorporate a metronome on it. So if that is something that's really helpful for you in your freezing episodes, it can be helpful that there's just kind of a button and gets it going. The second one in the middle here is called a four-wheel walker. With these, I'm not giving these to people who already have balance issues. It's a very mobile device. It's got brakes. Those brakes are just kind of more of a suggestion more than anything. These are for ones like if you're having a hard time getting all the way from the parking lot at South Meadows up to the hospital and it's a trek, or you're trying to get around Costco on a Saturday and you just quite don't have the energy to do it, then we could kind of have a conversation about those. I know everybody loves them because they have a seat, and I totally get that, but it's really, like, they're really unsafe relatively. Like, it's got to be the right person at the right time. The gray walkers we just don't have pictured here that everybody kind of thinks about. Those have two wheels. Those are going to be for people who are feeling relatively off balance because it's just less mobile in nature. Moving forward in the disease, if you're looking into, like, you are not safe to walk into your doctor's appointment, kind of the bottom left here is called a transport chair. Not a traditional like wheelchair. It's really just more about the caregiver being able to get someone in their safety. There has to also be a time and conversation as we're progressing into this disease about wheelchairs. Part of the problem with a wheelchair is most insurances are only going to buy you a wheelchair every 5 to 7 years. So there has to be a conversation about what it's going to look like 5 years from now, right? So sometimes people are just like, oh, I just want one of those little chairs you can get from, Amazon that I just push around. And if you let insurance buy you that, that's fine. But if 5 years from now you do need something with more like a power wheelchair and more capabilities, and that's why all of this, again, should be done with your physical therapist. You guys are going to be able to have like a conversation about how you're performing now and how you might be performing 5 years from now, kind of planning for the future. Other things we have to consider when it comes to using devices, like I mentioned earlier, about 80% of people are going to experience some type of dementia with Parkinson's disease. There does come a point in dementia that I can't teach you to use something new, and it becomes a fall risk. Like if I put a walker in front of somebody who's never used one and they don't have the ability to learn new things, they're going to try to climb over it, trip over it. I've watched patients literally try to climb over a walker because they don't have the ability to understand what it is. So there comes a conversation with your PT again, at what stage do we just start trying to use something that maybe right now you can kind of get away with fumbling around, well, maybe sometimes starting to initiate that sooner just helps in the 5-10 year from now plan. So diving in a little bit into more Parkinson specific PT programs. So this is the LSVT Big and the PWR Power. I personally am certified in LSVT Big, so we'll spend a little more time talking about that. But this just gives you a quick visual of what kind of the overlap and the differences are. The biggest difference is honestly the LSVT Big is a very strict protocol. So it is 4 times a week for 1 hour for 4 weeks. Versus Power has a little more flexibility. It's not quite so set in stone. Also with PWR, it has like a group aspect. I know a lot of people will do that. Rather than Big, it's got to be just one-on-one with that certified therapist. They both have great evidence-supported approaches, meaning there's great research behind both of them to help support individuals who have Parkinson's disease. This is a visual of, there's 8 maximal daily exercises that you perform with Big, with their emphasis on posture, improving range of motion, stability, strength. And then with the next one, PWR, again, very similar concepts. I do like PWR's, some of their exercises, because man, getting on and off the floor is a huge thing with every patient that I have, but especially with Parkinson's disease, and that's one of their big principles. So what would an LSVT Big session look like? So again, 4 times a week for 4 weeks for 1 hour, and it's gonna hit some function of all of these concepts. So there's always gonna be a walking aspect, really focusing on big steps, big movements. That walking might be outside, maybe it's carrying weights, maybe it's groceries. Then moving into the different types of tasks. So there's a functional task and a hierarchy task. These things are something you would establish with your therapist at eval, because as Lauren pointed out, that salience, we want it to be important to you. If your chore is taking out the garbage, let's work on the tasks that help you take out the garbage. Or these examples, so your hierarchy task might be gardening. So then one of your functional tasks might be being able to stand up from a kneeling position on uneven ground. Or if your task is you want to be able to unload the laundry, so maybe your functional task is holding a squat for 10-15 seconds, right? Or I've had lots of patients who love going to movies, and those movie theaters are seats are tough. So maybe your functional task is getting off from a low, squishy surface. And then we're always gonna hit those daily exercises from that picture. And then with Big, there is 1 hour of homework every single day, 7 days a week. So some of the concepts associated with Big, the big one is amplitude. I'm focusing on the size of movement. We want to override some of those small, slow movements. That's also going to help us improving that active range of motion. We're also trying to cue more of an internal feedback. So as Lauren pointed out, external is so important, but especially earlier stages of the disease, I'm trying to get you as the individual to be able to recognize your small movements and then do something about it. I can stand over you and yell at you to take big steps for hours and hours and hours, but what's the point? Right? But if you were able to be oh, it took me 5 movements to put my jacket on, oh, I could have done that bigger. That's that carryover that it's really trying to drive change with. Another big concept is this recalibration effect. So with Parkinson's disease, oftentimes people can't even notice that they're taking small steps. A lot of times it's their loved one that sends them to the neurologist because oh my gosh, you're just walking so slow and you're taking forever in these teeny tiny steps. So what I'm trying to do is with that concept of big, if I can retrain you to take a big step, and your brain's gonna think you are just taking some giant obnoxious step because your brain thinks that this is a normal step. We're looking to recalibrate. So after the end of that 4 weeks, you should be able to be walking and taking steps at what is more of a typical stride length for someone of your size and those sorts of things. And that's kind of the biggest goal. I want you to figure out that you were doing something small and making it big. Already also talked upon by Lauren, intensity. I want you sweating. It should be high effort. Let's drive change. And then that dose, repetition, difficulty. So earlier in our presentation, all of these things, all of this research that we were presenting to you guys is again, just being further pushed through with these big concepts. We want you to be motivated. People with Parkinson's disease are gonna need more reps to learn. That's where that 4 times a week kind of comes in. More reps, more repetition. I also really like the big aspects where if you're coming in 4 days a week, I might be able to catch you at a bad time, which like, so many people come into therapy and they're like on their on period and they're crushing it and everything's great, but then they get home and like, I can't get off the couch and I can't this and I can't do all these things. Sometimes having that higher frequency allows you to come in like, man, I didn't sleep at all last night. I took my pill 2 hours late and I'm a hot mess today. Great. I kind of want to see you when you're a hot mess, because that's when I can drive change of like, okay, when you come in perfect, I love that. That's great. But like if you're spending hours at home where you're having a hard time and I can see you in that period of time to at least come up with other strategies, like that's what I want to do. All right, so should you do like a Parkinson specific program? It totally depends on what you want to do. I'll tell you from a big perspective, I think it's really hard for people to buy in because 4 times a week for an hour for 4 weeks, if I have a $25 copay, like I don't have $400 to give you. Or if I'm trying to get my daughter-in-law to bring me to therapy, like finding transportation like at that high of a frequency can be really hard. And I understand that. And even in general, like as a big certified therapist, I don't provide big services anymore because our sessions are only 45 minutes in length. So I'm not really doing that, but I'm applying all the concepts. And this is not new. So even for people who aren't certified, like if you're a neuro-trained therapist, like these are hard-driven concepts into our everyday. So you can always start with traditional therapy and kind of go from there. I do really love PWR in that group setting, like being able to have, like if rock steady boxing is not your thing, being able to access some kind of group activity and then applying those concepts can be helpful. So really it's up to you. If you learned nothing else from today or from your physical therapist you've ever seen, exercise is the only thing research has found to slow the progression of the disease. It's not your medicine, it's not, sunshine or supplements, it is exercise. So making sure you are hitting that exercise at that intensity. So this next slide just summarizes, like you are hitting some kind of aerobic exercise. Like Lauren said, if you hate swimming, fine, don't go swimming. Like if you hate the treadmill, don't do that either. The best exercise that anybody ever could do is the one you like. If someone told me that swimming was going to be the greatest exercise, it's not going to happen. Hate swimming, hate it. So whatever it is that you like, do it, and then do it at an intensity that's meaningful. So many people come in and like, oh, well, I went for like a 2-hour walk. You're right. Something's better than nothing, but putzing through Costco for 2 hours doesn't count. Hot and sweaty exercise. All right. Any thoughts, questions, concerns?
I have a bigger.
Yeah.
Would you please repeat the question so that people understand?
Yes. So earlier, a gentleman had a question about when to determine what your intensity of strength training or how heavy you should be lifting. And Lauren's answer was basically, if you're doing a set of 10 or a set of 12, by the time you get to set or rep 8, 9, 10, you should be tired. You should be wanting to take a break. If you can do 30 in a row, that is not anywhere near your 80% 1 rep max. Again, something's better than nothing, but you should be tired. If you've been doing the same workouts for the 10 years at the same 5-pound weight, it's just not driving enough change to help make impacts with this disease. Anybody else have any questions? Yeah.
So I've been sent to PT, but it's only 2 days a week, and it's for 15 sessions that you've done.
Mm-hmm.
So what I'm hearing you saying is we need a physical therapist throughout the disease progression to help us along. So what do I do now? I mean, when the 15 sessions are up, which is going to be a couple of weeks, a lot of what you show here is what they've showed me to do at home on my own, but they're not going to give me any more sessions.
Yeah. So his question is basically, he's got 2 times a week of therapy for 15 visits, but then what? And then through our presentation, it does sound like you do need physical therapy throughout many aspects of life, which is 100% true. The way I treat individuals with Parkinson's disease is through tune-ups. You come in, I get you going on a homework program. Because as Lauren said earlier too, it's not my goal to keep you twice a week for the rest of your life. You got stuff to do. I want you to feel confident and comfortable managing your disease at home. So I want to give you as many tools in your toolbox. I want you to understand that you should be hitting your aerobics, and I want you to have a great strength training program, and I want you to have some great, stretching and all those kinds of things, and then going to a community-based program. Or if that's not your thing, keep going with your current, home program. And then I tell people, if you start noticing you're feeling a little sluggish or you're not quite where you're supposed to be at, you can always get a referral and come back. Sometimes there are insurance limitations, right? Which is just the nature of the healthcare system. But it shouldn't just be like 15 sessions, you high five, and I see you 20 years from now. Like if at any point you're noticing changes, getting another referral and going back to seeing that therapist. Does that kind of answer your question, or? Okay.
I kind of like to explain it. Somebody proposed it as almost like the dental model. So we go to our dentist twice a year. They do a checkup, make sure things are going okay, and then they send you along to hopefully just keep brushing your teeth. And all of us are very tuned into that. I kind of approach PT fairly similarly, where, every 6 months, if things are going pretty well, I'd still love to check in, even if it's 1 or 2 visits, and we say, great, your exercises are good, your balance objectively is looking pretty good, you don't need extensive PT, we don't need another 15 sessions right now, go on your way, and then, we can check back up in another 6 months. When things dramatically change, when we notice big, changes in our mobility or something else, then, we may extend that a little bit and see you for a little bit more time. But yeah, I kind of think of it like you go to the dentist every 6 months or so, and typically, depending on insurance, but typically they will cover that for something like Parkinson's, because again, the disease does change, and we can justify, hey, we need to make sure that objectively we're not seeing big changes.
What's your experience with the VA on that kind of thing?
So his question specifically to the VA. So the VA will give you a 15 visit chunk. You don't have to use that 15 visit. They're also going to give you a time period. Usually it's about like 4 to 5 months in that time period. And a lot of that is discussed between like you and your physical therapist, right? So if you only use 8 visits and then your period that was approved is 4 months, so maybe 2 months from now you go back in. Otherwise, like I've never had the VA not put in another referral. So if you do your 15 visits now and 6 months from now, you're like, man, I don't feel good. I've never had the VA not approve more visits and put in a new referral. It's just, sometimes it's just the hoops of it all. Like you have to go back to your VA doctor. They have to approve that you go to somewhere other than the VA if that's where you're going, and then. But I've never had them say no.
And I will say, as much as we kind of blame insurance for limiting things, I've rarely had an instance where I am struggling to get somebody authorized when it's medically necessary. Mm-hmm. And with a progressive disease, doing it in a, routine way of checking up every, 6 months is, in my argument, very much medically necessary. And so as much as insurance does dictate so much, I haven't personally had to tackle a lot of denials. So
I agree.
That's the good news.
I think we chart pretty well to prove that you're doing well and that you should be here.
And that's on us, not the patient.
And I think we also do a good job of telling people when it's time to go. To go do rock steady boxing, because that's where I think insurance auth starts to become a problem, is if you've been going twice a week for 5 years, that's not effective.
Is there too much for the patient to do? Like PT twice a week, swallowing twice a week, rock solid boxing every day, stretches and exercises 3 times a week, all at the same, is that?
Yeah, so her question is, it just seems like a lot. If you're going to speech therapy, OT, PT, and you're working out, you're right. So sometimes I'll just encourage people to prioritize. Like if you're having a really hard time swallowing and you really only have the bandwidth to go to 1 or 2 appointments a week, do that. For those people who just want to do it all, great. Let's do that. And you can meet yourself in the middle too. Like it's just about priorities. If you're coughing on your saliva, but you don't have the bandwidth, let's not go to PT today. Let's maybe spend a couple weeks in speech and those kinds of things. The best way from an exercise prescription, there's not too much. If you're tolerating it and you feel good and you want to do all those things every single day, great. But yeah, there comes a time where you're like, it took me 8 hours to do these exercises, so I'm going to do nothing. And that's where, from a PT perspective, that's a lot of conversation. I'm not going to hand you 400 exercises and a high five and hope for the best. Like, it's going to be very like, hey, well, what do you think you can do? Like, you think you can start with 10 minutes? Great, let's do that. And then a couple weeks later, like, okay, now let's try to add a 10-minute walk and that kind of thing.
And my discussion with patients too is always, you got to live your life as well. If you are spending all your time exercising and then missing out on your time with your grandkids or the things that you love, I'm always like, pause the brakes. You need to be doing the things that are the most meaningful. And if that includes, spending time with family, going out, doing, fun things, doing hobbies, going bowling, please keep doing that. I'm like, whenever somebody's like, I'm so sorry, I had to cancel physical therapy, my granddaughter has a soccer game, I'm like, stop it, go to the soccer game. Great. Like, we want to improve quality of life at the number one goal. It's about you as a patient. And so if the load is, then weighing you down, we need to reconsider goals.
The 3 stages of the disease that you talked about, how is that determined? Is that a numerical evaluation, or is it a subtle evaluation by the doctor, or how is that?
So his question is regarding like the stages of Parkinson's disease. So Hone and Yar is established by like the physician. So there's lots of different things they're looking at. It might be if you have only one arm that's involved, like with a tremor, versus 4, versus like your walking speed. And it's all just related to the doctor's diagnosis. From a physical therapy perspective, it's something we might glance at before you come in to have an idea. Like if you're coming in, at stage 1, it might just adjust what I plan to do in that evaluation versus stage 5. But otherwise, it's kind of just the way they're tracking symptoms. It's not relevant to like what their diet, like what their medications they're giving you. It's more research oriented than anything. Like if I have a patient who's in like stage 5, I might be able to look up specific research for things that I could be doing for stage 5. So you might see it like in your chart. You might open it up and it might say like H and Y stage 3. But otherwise, it's not something that is used often.
Because I've gone through a lot of evaluations, but I've never seen that one.
Yeah.
In person.
You could look in your chart. If you might look back through your physician notes, it's probably in there.
Like Dr. Turong usually puts it like in the notes somewhere.
He puts it in, Dr. Trump puts it in your my chart notes.
It's not something that I find the neurologist is like telling a patient. Like it's not usually something where you leave the visit with that as a critical thing. It's really more from like a neurologist diagnostic perspective.
Because like I said, it's not going to impact like, oh, you're in stage 3, now I'm going to add this medicine. Or, oh, you're in stage 1, now I'm going to send you to PT. It's really just like medical hubbub. Yep.
If you have Parkinson's, the way I look at it now, I was diagnosed in 2017, it's my job. So it's not that I have a disease and I need to take care of myself. I have a job, and that's to stay alive and not let it take me down. I agree with that.
Yeah. All right. Yes.
If I already have a referral to go to you guys, is there a specific number I should call? Or
Yeah, so if you wanted to come to Renown physical therapist to like see either Lauren or I, you do have to get a referral from your doctor, and they'll schedule you. That number is 982-5000.
I also have my cards in the back. If
Lauren,
you need.
yes, I forgot my cards. The tricky thing is in healthcare, and I'd say it's like I have friends all over the country, but there's like a wait. And I tell people, if you're going to be really passive and they tell you that Lauren doesn't have an opening till August and you want to wait till August, that's fine. But if you're ready to get going now, call frequently. You can move up. Like we get cancels every week. So if you're scheduled in August and you want to get in sooner, then be making those calls. You're not bothering anybody. And it's okay to also be passive. If you're okay to just wait till August, there's nothing wrong with that. But if you're sick of waiting, and that's the same if you're trying to get into a doctor. Like if you're on the wait list to see your cardiologist in December, like call.
The squeaky wheel gets the grease.
Yes. Yes.
Is that same call if you want to get in earlier than you have an appointment for work for Dr. Throne?
She's asking if trying to get in sooner to see Dr. Turong works the same way. I'm assuming. I mean, in all reality, If you call Monday morning and someone canceled because it was snowing, which I mean, it's March, it won't snow anymore, now that it's 80, but like, you might get lucky. There might have been a car accident coming from Winnemucca and someone canceled. You might get lucky that there's an opening at 11 a.m. Like, I don't think you're wrong to call regularly, because there's all types of reasons. If someone gets the flu, they might cancel their appointment, or they might get a flat tire. Like, if you're interested in getting in to see any doctor in any healthcare system, that's the best way to do it, is call.
Especially if something really changed. Like if something is really dramatic and you had a visit in 4 months and then all of a sudden things are just, something really took a dramatic turn. Dr. Trong, our movement disorder specialist here in Reno, he is so, I feel like accommodating to that. And so if there was something, that really needed that attention, again, I haven't had folks have issues with that.
Yeah.
We can't speak directly on his office principles,
Right.
but I would assume they would get you in.
Yeah. He's also very great communicator. So if there was some rapid change, I'll tell people too, if you're falling, if all of a sudden you wake up tomorrow and you fall 5 times, that's not a physical therapy issue. That is some kind of medical management issue. So that means you either need to get in, communicate with your Parkinson's physician about medication changes, or honestly something that's super common as we age is UTIs, which I know sounds crazy, but I've had people go from walking and fine to falling 5 times in a day, all because they had a UTI. So I want you to keep that in mind too. If it's a rapid change, don't wait 6 months to see me. There's something else happening. If slowly over time you're like, oh yeah, I fell last month, and then yeah, I fell getting out of the shower, I wasn't paying attention, sure. But if you just wake up one day and are falling a lot, that's not a PT issue.
And Dr. Trong is flexible. I see him at 7 o'clock in the morning. So,
And then just to specify, a UTI is a urinary tract infection, which especially when we're younger, we think of that burning when you pee or going to the bathroom all the time. But honestly, as we age, we don't get those symptoms as often. We start getting movement changes, falling, trouble getting up, or also cognitive changes. If someone is acting really rapidly confused and not making sense, a urinary tract infection can be just on the radar.
I have one more thing about Rocksteady. I bet you see my neighbor. And that is for Rocksteady, you may think that, and we've been doing Rocksteady since 2016, 2017, but there are people at our Rocksteady that are on their rollators and or their spouse is their care partner and they're wearing a belt and they're holding them so they don't fall over. Don't think you can't do it because you're not ready. Go and get your act together and show up. So, and it's hard, but that's the only way you'll improve.
For those watching, she was just telling us her truth about Rocksteady and that anybody can go. So if you're needing some physical help, they're able to make those adaptations and stuff for you. So yeah. All right. Any other questions or thoughts?
I have one more.
Yes.
I don't mean
You're fine.
to take every time, but how critical do you think it is that your PT have a specialty in this Parkinson's or, movement disability?
Yeah. So his question is how important do we think it is for a physical therapist to have some kind of neurologic training, basically? Not to sound biased, I think that a lot of my coworkers are great orthopedic therapists. They'll treat your headaches, your neck pain, all kinds of stuff. And if you went and saw them for your Parkinson's specific needs, it's unlikely you'd get that much better. Only in the sense of just training and what I spend my time doing. So when I'm doing training for becoming a better physical therapist, I'm gearing it towards individuals with Parkinson's disease or strokes or spinal cords. And that's going to help keep me up to date on the most recent literature and applying these kinds of techniques versus if you came to see me for your ankle pain, I could treat your ankle pain, but maybe what takes me 5 visits to get you going for your Parkinson's disease might take someone else 20. If they just don't have the training. Do you have any other thoughts on that?
Yeah, I mean, I don't even know. I think it's, if the PT has an interest in it, even if they don't have a specific certification, but if it's something they see regularly,
Yes.
I think that, if it's somebody that is a, expert in treating the neck, who you happen to land on their caseload, they may just not have that kind of drive and passion for it or interest in it. But again, I think as long as it's somebody that sees it regularly, is in the know about updated things, I think it can be helpful, but I do think it is something that we approach very differently than, just an orthopedic issue or, what you might go to, like if you saw your PT for your knee replacement, they may not be the best person to see for Parkinson's, but they may, also love doing that. So it's one of those classic, it depends, but you just want somebody that's in the know.
Sometimes I'll treat that with like your primary too. Like you'll go to your movement specialist to help you manage your Parkinson's disease. Your primary they might do a pretty good job, but there comes a point where they kind of reach like, hey, I can't help you more than this, and they send you to a specialist. So same thing, like if you just kind of started with a PT, they might reach the point where like, hey, this is above what I am trained to do, and then could send you to a specialized train. But you don't need all the fancy letters after your name from a PT perspective to just love and be passionate and have a good understanding of neurologic conditions. Yeah.
How many physical therapists are at Renown that are specialized?
So the question is how many Renown outpatient therapists are specialized? There's 3 of us. So there's 2, one is part-time at my location on 2nd Street, and then myself, and then Lauren is full-time at South Meadows.
Any other questions?
I have a comment.
Yes.
To the group. We've had a lot of physical therapists come through Rock City Boxing just to see what it is that we do. And almost universally the comment is, well, we take people through what we're allowed to either by the insurance company, and then we don't have anything for them to do. We can't help them after that. And that's, I think, where Rock City Boxing provides a lot of follow-up past that, is that once the physical therapist has run out of their money or whatever the case may be, here's an organization that's very cheap, that you can get involved with and still exercise like they want you to exercise. It's also you like family.
Or you can join us bowling, right, Kallee?
That's right. Bowling.
You bowl.
I've done twice now. It's a blast.
All right.
On Thursdays?
Yeah.
Yeah. You was there Thursday, you weren't.
No, we weren't.
Well,
All
thank
right.
you all for your time. We really appreciate you all coming out. And again, if you have questions, my card's at the back. Feel free to email me. I can always forward it along to Kallee. But yeah, and thank you for the Parkinson Support Center. They're doing unbelievable work in just keeping education and community as the center of this disease. So thanks again to Anne for having
Yes.
us, and just all the great work you guys do too. So
Thank you.
Thank you all.
Thrilled to have you.